Okay. So according to definition, the ideal tooth extraction is the painless removal of the whole tooth or root with minimal trauma to the investing tissue so that the wound heals uneventfully and no post-operative prosthetic problem is created. It was given by Jeffrey and Ho. Because the most important thing in this definition is it should be painless. If there is pain, if the patient feels pain, then it is not ideal tooth extraction. So type of extraction, basically there are two types of extraction, closed extraction and open extraction. Open extraction, we also call it as a transalveolar extraction or surgical extraction, and commonly we follow the closed extraction or intra-alveolar extraction where you use only elevator, peristral elevator, straight elevator, and forceps. So indication of extraction are advanced caries, as you can see in the figure. If the caries has extended beyond the cemento-enamel junction, if it is unrestorable, you can do the endodontic treatment or post and core. Then the last option is extraction of tooth. And the reason is if the whole of the crown is gone, usually in case of geriatric patient, if you can't do anything in such cases, then again in case of advanced caries, if it is not restorable, if it is not salvageable, then you have to extract the tooth. Next is periodontal disease. In case of chronic generalized periodontitis, if the bone loss is severe, if the tooth is grade 3 mobile, if it is a one-wall defect, you can do the bone graft. Then in such cases, again, the last option is extraction. And there is impacted tooth. There are many complications associated with impacted tooth. It may lead to recurrent pericoronitis. It may lead to caries of saving. So you have to extract the impacted tooth as well. And there is orthodontic purpose. Most commonly, we extract first premolar tooth for orthodontic reason. Other tooth can also be extracted, but the most common is first premolar because the space created by the extraction of first premolar can be used for alignment of both the anterior teeth as well as posterior teeth. So usually we extract first premolar teeth for orthodontic purpose. Another indication is if the teeth is associated with any cyst and tumor. It is a case of odontogenic keratocyst where there is anterior-posterior expansion and it is associated with third molar, second molar, and first molar. So we have to enucleate this lesion along with the extraction of these teeth. Otherwise, it will lead to recurrence of the cyst. Other is the case of amyloblastoma where it is associated with again first, second, and third molar again where while removing this tumor, you have to extract the associated teeth as well. If you don't remove the teeth, it will lead to recurrence. So one of the indications for extraction of teeth is if the teeth is associated with any cyst or tumor, especially in case of odontogenic keratocyst and amyloblastoma. Usually recurrence is very rare in case of dentigenesis. Another reason for extraction can be tooth with necrosed pulp or periapical lesion, which is not responding to endodontic treatment. So if there is pulp necrosis, if there is periapical infection, the first line of treatment is endodontic treatment. Or I prefer episectomy and single visit endodontic. In the same visit, you can do episectomy and root canal treatment so that you don't have to do root canal treatment. You have to wait for 6 months or 1 year. You have to take the radiograph. If you don't know whether it is healed or not, because even though the wound is healed, in the radiograph you'll see only radiolucence. You may not know whether it is still infected or it has been healed. So it's better to do single visit RCT and episectomy in the same visit. So you are sure you have seen it clinically, you have removed the lesion. So it's better to do root canal treatment and episectomy in the same visit. Though the conventional treatment is root canal treatment in endodontic management. If the tooth is not salvageable, even with endodontic treatment, then again you have to extract the tooth. If there is bone loss, if the tooth is mobile, if the patient don't want for endodontic treatment, then the option is extraction. Unrestorable tooth, if the tooth is vertical fracture, then again, in case of vertical fracture, you can't do anything, you are helpless, you have to extract it. If it is horizontal fracture, then it depends on position and clinical scenario. If the horizontal fracture is present in apical third, you can do root canal treatment, you can save the tooth. If it is present in middle half, it depends. If you have to check clinically, if it is mobile, then you have to extract, otherwise you can save. If the horizontal fracture is present in the coronal third, most of the time it is mobile, then you have to extract the tooth as well as you have to remove the root. So in case of horizontal fracture, it depends on the position and factor, location of factor. But in case of vertical fracture, you have to remove the only treatment is extraction of teeth. You can't do anything in such cases. And there is retained deciduous teeth. In case of retained deciduous teeth, if the tooth is not exfoliated, then you have to extract the tooth. But the most important thing is you have to take the radiograph first, because the permanent tooth may be missing sometimes. This is the first figure. You can see there are multiple erupting tooth pods are present. These are permanent tooth and there is present deciduous tooth. If the permanent tooth pods are present, then you can extract the retained deciduous tooth. But sometimes what happens? See, it is one of our surgical patients. We found accidentally there is presence of retained deciduous tooth. Okay, you can see here in the region of second premolar, it is a deciduous second molar tooth. It is an old age patient. There was condyle fracture and left parasymphysis fracture. We have operated this, and while taking the OPG, we found that there is presence of deciduous tooth, and there is no succeeding tooth board of no succeeding permanent tooth board. Okay, sometimes it may happen. So if there is no permanent tooth boards, there is no permanent teeth, then you have to retain that teeth. So that's why even though if there is presence of retained deciduous teeth, you have to take the radiograph first. First, you have to confirm whether the permanent tooth is present or not, because sometimes the permanent tooth board may be missing. On this prosthetic purpose, because in case of old age patient, the tooth may be tilted. If you see this third molar, even if you remove the second molar, you can't put any prosthesis because the third molar is tilted. During that condition, if you are planning for prosthetic rehabilitation, you have to remove all the hopeless tooth. Other supernumerary tooth, most common supernumerary tooth is unerupted mesoidents in the midline of maxilla, and the most common cause of midline diastema is also unerupted mesoidents. So if there is presence of any supernumerary teeth or mesoidents, there is tooth in the fracture line. So if the tooth is present in the fracture line, it again depends on the condition. In all the conditions, you don't have to extract the teeth. If the tooth is fractured, if it is associated with pathology, cyst or tumor, or tooth itself is carious, or if interfere with occlusion. If the bone can't be reduced without extraction, then you have to remove the tooth. And in other cases, in most of the time, you don't have to extract the tooth, even though the tooth is present in the fracture line. Teeth in the area of radius therapeutic radiation, if the tooth is carious, then you have to remove the tooth before radiation therapy, because what happens after radiation therapy, there is 3H effect: hypocellularity, hypoxia, and hypovascularity, which will lead to osteoid necrosis. And also the salivary gland will be atrophied. There will be no salivary secretion. The chances of caries is very high. So in such cases, the chances of osteoid necrosis is more. So the hopeless tooth, carious tooth has to be removed before starting the radiation therapy. And ideally, all the tooth should be removed about 21 days before the radiation therapy, so that the wound will heal uneventfully. Okay, so you have to remove or extract the tooth 3 weeks before the radiation therapy. And usually in the oral cavity, in the maxillofacial region, squamous cell carcinoma is very common. And even after surgical excision, there may be some presence of some positive border. There may be some malignant cells may be present. For that, you have to do radiation therapy. If radiation therapy is planned, you have to remove all the hopeless tooth before starting the radiation therapy. Ideally, it should be removed 3 weeks before radiation therapy. Contraindication for extraction include absolute contraindication are central hemangioma or arteriovenous malformation, because in these cases, if you extract the tooth, there will be severe bleeding and you can't control the bleeding. Relative contraindication are local contraindication like therapeutic radiation. If the patient has undergone radiation therapy for any cancer or malignancy, then in such cases also it's better to avoid extraction because it may lead to osteoid necrosis. If there is presence of malignant tumor, again, if there is presence of malignant tumor, if you do extraction in such cases, it will lead to CD metastasis. The malignancy will be spread. And the reason is severe peritonitis. So it is a traditional technique method that if there is it is said that if there is severe peritonitis, you should not extract the tooth because it will lead to spreading infection. But nowadays it is not followed. Even though if there is presence of severe peritonitis, if you extract the tooth and you prescribe the medications, it will be healed uneventfully. You don't have to worry. So it is a case of pre-antibiotic era. In pre-antibiotic era, it was said that the tooth should not be extracted if there is presence of severe peritonitis, but it is not followed nowadays. You have to remove the cause. Once the cause is removed, once you have removed the impacted third molar, it will heal uneventfully. You have to prescribe the medications. So severe peritonitis is not no more contraindication for extraction of involved teeth. Systemic relative contraindication are Uncontrolled diabetes mellitus, if the blood sugar level is high, there will be delayed wound healing because the chances of infection is more because the neutrophil could not phagocytose. So in case of uncontrolled diabetes mellitus, if the blood sugar level is high, it's better to avoid extraction. First, the blood sugar level should be controlled. In case of uncontrolled leukemia or lymphoma, in case of leukemia, abundant amount of blood cells are present, but unfortunately, all of them have qualitative defect. Even though the quantity is more, but they could not function normally. So due to the white blood cell count is less, it could not function, so there is chances of infection, platelet count is also less, so it will lead to bleeding. In case of pregnancy, it's better to avoid extraction. If you have to do, it's comparatively second trimester is safe. In first trimester, you should not extract the tooth because due to stress, it may lead to some developmental malformation. So it is said that during the first trimester, the organogenesis is going on, so it's always better to avoid any trauma, any surgical procedure. And in third trimester, again due to our medication or stress, it may lead to premature labor. So in order to avoid the premature labor, again in the extraction or any surgical procedure is not advised in third trimester. Comparatively, second trimester is better. So you can extract the tooth in the second trimester, preferably in 5th month. So conclusion is it's better to avoid extraction in pregnancy. If you have to do, you have to benefit versus risk. Comparatively, second trimester is best. Even in the second trimester, the 5th month is better. You should not extract the tooth in the first trimester because the organogenesis is going on. It will lead to developmental malformation. In the third trimester, it may lead to premature labor. So you have to avoid any surgical procedure in the first trimester and third trimester. Comparatively, second trimester is better, and it is best to avoid any surgical procedure during pregnancy. There is malignant hypertension. Malignant hypertension means if the blood pressure is more than systolic blood pressure is more than 200 and diastolic is more than 140, then it's known as malignant hypertension. In such condition, you should not do any surgery. It may lead to severe bleeding, it may lead to cerebrovascular accident or acute myocardial insufficiency. And there is thrombocytopenia. The platelet count, normal blood platelet count is 1.5 lakh to 4 lakh. So if you are planning to do any surgery, it's better to have a platelet count more than 1 lakh. If it is less than 1 lakh, then it's better to postpone your surgery. And there is bisphosphonate. Bisphosphonate is usually prescribed in case of postmenopausal women because in such patients there is deficiency of estrogen, which will lead to osteoporosis. And the treatment of osteoporosis is bisphosphonate. And bisphosphonate will prevent resorption of bone. And the problem with bisphosphonate is if the patient is taking some bisphosphonates, the chances of medicine-related osteonecrosis of jaw is very high. We also say bisphosphonate-related osteonecrosis of jaw. Again, in such patients, it's better to avoid extraction. Immunosuppressive agent, if the patient has undergone liver transplantation or renal transplantation, nowadays renal transplantation is very common, and in such patient has to take immunosuppressive drug for lifelong. And in such cases, be careful because the chances of infection is very high in such patients. Hemophilia, so you have to take BT-CT, PT-INR, and depending on the severity, if the PT-INR is normal, you can proceed for any surgical procedure. If it is not, then you have to do blood transfusion. You may have to infuse a specific clotting factor, whether it is hemophilia A, B, or C. Clotting factor 8, 9, or 11. In this renal disease, in case of renal disease, you have to see the urea creatinine. If the urea creatinine is normal, if the patient is undergoing dialysis, then you have to. What happens in case of dialysis is during dialysis they use anticoagulant heparin. So you should not extract the tooth or do any surgical procedure on the day of dialysis because during dialysis anticoagulant is used. Usually low molecular heparin is used during dialysis. So the chances of bleeding is more. So it's better to avoid any surgery on the day of dialysis. You have to do your surgical procedure after 1 day because if you wait for 2 to 3 days, again the urea creatinine will accumulate in the blood. And again, the urea creatinine level will be high. So you have to see the blood report for urea creatinine. If it is normal, then you can proceed with your surgical procedure just 1 day after dialysis. And usually, dialysis is done twice a week in most of the patients. Radiographic assessment, always when you are planning for extraction of a teeth, you must take a radiograph, because in case of maxillary sinus, there may be the posterior tooth may have entered into the maxillary sinus. It's again, especially in old age patient, as you know, as the age increases due to pneumatization of the maxillary sinus, the size of the sinus increases and the root of the tooth may be present inside the maxillary sinus. So in such cases, if you don't do radiograph, if you extract the tooth, it will lead to oroantral communication. There may be presence of periapical infection, the root may be fractured, so it's always better to take some radiograph and then proceed with extraction. Another reason is sometimes tooth may be dilacerated. So in such cases, if you don't do extraction, if you don't take radiograph and if you proceed with extraction, what will happen? It will fracture definitely, it will not be luxated. So again, to check whether the teeth is dilacerated or not, you have to do radiograph. Another reason is there may be presence of hypercementosis. Again, in case of hypercementosis, the root is bulbous, you can luxate the tooth or extract the tooth. So principle of exorgency are, first thing is pain and anxiety control, then position of the patient, position of the operator, clear access and vision of the surgical field, use of controlled force elevators and forces, and finally unimpeded path of removal. So usually we prefer local anesthesia for extraction of teeth. It is for routine extraction, or in some cases, if the patient has some cerebral issue, like on cooperative patient, if there is cerebral palsy, if the patient is epileptic, then you have to go for general anesthesia. Position of the patient, if you are planning for extraction of maxillary teeth, so the chair is tilted back so that the maxillary occlusal plane is at about 60-degree angle to the floor. Okay. For mandibular extraction, the patient is more upright so that the mandibular occlusal plane of the open mouth is parallel to the floor. In case of maxillary extraction, maxillary tooth extraction, maxillary occlusal plane should make an angle of 60 degrees with the floor. In case of mandibular extraction, the mandibular occlusal plane should make an angle of 0 degrees. It should be parallel to the floor. Also, height of dental chair. For maxillary teeth, chair height should be adjusted so that the site of operation is about 8 centimeters below the shoulder level of the operator. It is about 3 inches, but in case of mandibular teeth, it is about 6 inches or 16 centimeters below the elbow level. Another technique is your elbow angle should make an angle of 90 degrees while extracting the maxillary teeth, and your elbow angle should make an angle of 120 degrees when you are extracting the mandibular teeth. Position of the operator in all the extraction, you have to, on right, if you are right-handed, you have to stand at 8 o'clock position. Only in case of lower right posterior teeth or fourth quadrant teeth, you have to end to at 12 o'clock position or rearmost position. In triangular extraction, the parts of forceps are, it consists of beak, hinge, and handles. In case of elevator, it has working end, shank, and handle. So difference between the mandibular tooth and maxillary teeth is you have to look for beak and handle. In case of maxillary forceps, the beak and handle are parallel to each other, but in case of mandibular forceps, the beak and handle are perpendicular. So don't be confused, especially in case of third molar. You have to look for beak and handle. If they are parallel, it is maxillary forceps. If it is perpendicular, it is mandibular forceps. Mechanical principle, it works on the lever principle, wedge principle, and wheel and axle principle. Lever principle, in case of lever principle, mechanical advantage is 3. Okay. Forceps and elevator works on the lever principle. It works on first class lever. Fulcrum is between the load and the effort arm. To gain a mechanical advantage, the effort arm on one side of the fulcrum should be longer than the load arm on the other side of the fulcrum. What do you mean by the mechanical advantage 3? While extracting the tooth, while using the elevator, it is your effort arm, this is your load arm, it and the alveolar bone will act as a fulcrum. Now, what do you mean by the mechanical advantage 3? It indicates that whatever force you apply in the effort arm, okay, that is multiplied by 3 times. The same force will be multiplied by 3 times in the tooth region. So the force is multiplied by 3 times in the region of load. It indicates mechanical advantage 3 means the force we applied in the effort arm will be multiplied by 3 times in the region of load. So forceps and elevator works in the lever principle. It works on the first class lever. Next is wedge principle. Again, force applied between the root and the bone along the long axis of the tooth. Application is elevators and forceps. Again, this works on the wedge principle. Its mechanical advantage is 2.5. It means whatever force you apply in the handle region, it is multiplied by 2.5 times. Okay. So while using the straight elevator, you have to insert an elevator between the root and the bone. In case of wedge principle, what happens? Whenever you apply the apical pressure in this area, the tooth will be extruded out. That's the concept. And while using a straight elevator, never use blindly, okay? Especially in case of maxillary palatal root. If you use your straight elevator blindly to remove the palatal root, it will enter into the maxillary sinus. Be careful, you have to insert your elevator between the root and the bone, not directly apply pressure over the root. If you apply your elevator blindly, you will put pressure over the root of the palatal root and it will enter into the maxillary sinus. And there is third principle is wheel induction principle. Its mechanical advantage is 4.6. It means that whatever rotative force you apply over the handle, it will be multiplied by 4.6 times in the region of root tip. So crossbars or crier work in this principle. It is used to remove, if in case of multi-rooted tooth, if one of the root is removed, it is used to remove the under root. So while extraction, you have to do socket expansion. Okay, use of elevator and fulcrum. Elevator works on the first class lever. Okay, E4 time. Where we apply the force, it is a E4 time. Where we contact the tooth, it is a load arm, and the ulnar bone acts as a fulcrum. So whatever force we apply in this region, it is multiplied and acted upon the load region of the tooth. So forceps also works on wedge principle. What happens whenever you apply the forceps for extraction, the first pressure you have to apply is apical pressure, so that the beak is inserted within the periodontal ligament between the tooth and the bone. When you apply the apical pressure, the tooth tends to extrude out. Role of left hand during forceps application: it helps in retraction of lip, cheek, and tongue region, guiding of the beaks of the forceps, stabilizing the patient's head. During tooth luxation, it helps in supporting the buccal and lingual cortical plate, prevention and protection against slippage of forceps and elevators. After tooth extraction, it helps in compressing the buccal and lingual cortical plate. Always after extraction, you have to compress the buccal and lingual cortical plate, but you are planning to replace the extracted tooth with implant, then you don't have to compress because you need wider bone later for insertion of implant, for implant replacement. Examination the surgical field for detection of sharp bony edges, undercuts, or loose bony fibers. If there is presence of sharp bony edges, you have to remove it using either bone file or bone bruiser. Various movement for extraction of individual tooth. For all maxillary teeth, you have to give first apical pressure, then more labial or buccal pressure, slight palatal with traction. Why more buccal or labial pressure in case of maxillary teeth? Because what happens in maxilla is, in buccally there is presence of loose, completely the bone is thin, it is loose, it can be luxated easily. But in palatally there is a presence of hard, compact bone, so palatal bone can't be luxated or it can't be expanded. So palatal bone consists of compact bone, it can be expanded. That's why in case of maxilla, the outward or buccal or labial force is given as more as compared to palatal force. And always while you're applying the forces, you have to give the apical pressure. It doesn't matter which tooth is this. So first apical pressure, then followed by buccal or labial. So in case of lower anterior and premolars, first apical pressure, then followed by equal labial and buccal, because on both sides there is the thickness of bone is equal. So you have to give the equal pressure both labially as well as lingually. But in case of lower molars, there is presence of thick external oblique ridge in mandibular molar region. So again, you don't have to apply excessive pressure buccally because the thick cortical bone external oblique ridge will not expand. So in this region, you have to give more lingual pressure because lingually there is presence of very thin bone. It can be expanded easily. So in case of lower molar, first is apical, then followed by more lingual, slight buccal with traction. So which force will you give? That depends on which tooth you are extracting and what type of bone is present in this region. In maxilla, there is presence of thin bone labially or buccally, and there is presence of thick cortical bone in palatally. So the palatal bone will not expand. We have to give more buccal or labial pressure. In case of lower anterior premolar, the thickness of bone is equal both lingually and labially. So after apical pressure, you have to give both equal buccal and lingual pressure. In case of mandibular molars, there is presence of external oblique ridge, thick bone. So the thick bone can't be expanded. Then the option left is you have to expand the lingual bone. So you have to apply the lingual pressure more with forceps. The rotational movement for extraction. There are only two tooths where we can apply rotational forces only: maxillary central incisor and there is mandibular second premolar, because the maxillary central incisor and mandibular second premolar are single rooted tooth and their roots are oval in shape, almost circular in shape. If you see the cross section, it is almost circular, it is oval shape. That's why you can give rotational movement only in case of maxillary central incisor and mandibular second premolar, not in other tooth. In multi-tooth tooth, if you give rotational force, it will fracture. Even in case of lateral incisor, most of the time the apical third is dilacerated distally, so again it will fracture. In case of canine, also it is almost triangular in shape. In first premolar, in maxilla, it has two roots, buccal and palatal. You can't give the rotational force, so only option left is you can give the rotational forces only in these two teeth, maxillary central incisor and mandibular second premolars. Steps for extraction are positioning of the patient, administration of local anesthesia, loosening of soft tissue and attachment from the tooth, and loosening of soft tissue attachment from the tooth, luxation of tooth with elevators, adaptation of forceps to the tooth, luxation of teeth by forceps, and removal of teeth. If you follow this sequence, it is easy. Never try to use forceps for luxation of tooth. Always you have to use first a straight elevator. Once the tooth is luxated, then only you must apply the forceps. So first is you have to maintain your position, because if the position is not maintained, the problem is you may have spondylitis later. So always when you are working, your backbone should be straight. Don't try to overbend. Okay. Next is you have to inject the local anesthesia. In case of nerve block, you have to wait for 3 to 5 minutes. After 3 to 5 minutes, you have to reflect the gingiva using number 9 Molt's periosteal elevator. Once you have reflected the gingiva, then you have to use a straight elevator. A straight elevator is always used at a mesial-buccal line angle. Once the tooth is luxated, then you can apply forces. If you can't luxate the tooth, the next option is you have to section the teeth. It may be multi-tooth teeth, it may have undergone ankylosis. So in such cases, you have to luxate, you have to section the tooth. Once you remove the tooth, then you have to compress the socket. You have planning for replacement with the implant. Then don't compress the socket, leave as it is, because you need more bone, more wider bone for placement of implant. And you have to prescribe analgesic mouthwash. Never prescribe antibiotic in all cases. If there is infection, if there is pus, if lymph node is palpable, tender, inflammatory, if due to inflammation, submental lymph node is palpable, then you have to prescribe the antibiotic. Otherwise, in routine extraction, you don't have to prescribe any antibiotics. Only painkiller and mouthwash is sufficient. Loosening of soft tissue attachment around the tooth is it is done using a number 9 periosteal elevator. It is known as periosteal elevator because primarily it is used to elevate the mucoperiosteal flap. It is used to elevate the periosteum. That's why it is known as periosteal elevator, though we use it for reflection of gingiva. Luxation on teeth with elevators. It is the straight elevator is used. Always use your elevator at the mesial-buccal line angle for luxation of tooth. And the force should be so that if the tooth should extrude out of the socket. Never apply the force in the opposite direction, otherwise you will fracture the crown part. Next, adaptation of the forceps to the tooth. Whenever you are using the forceps, the first force should be always apical. The beak should be inserted within the periodontal ligament between the tooth and the alveolar bone, so that the tooth will be extruded out. And as you hold your forceps more apically, the center of rotation also will be present more apically. So the chances of root fracture is also less. After that, luxation of tooth, depending on the thickness of bone, you have to apply the either buccal or lingual force. Apply the buccal or lingual force. Followed by removal of tooth, post-extraction tooth socket care, irrigation of the socket. Again, always you should not always irrigate the socket if there is presence of periapical infection. If there is periodontal disease, then you should irrigate. Otherwise, do not irrigate the socket, because the clot formed just after extraction is a good one. There it contains a lot of clotting factor and the chances of dry socket is less. So you don't have to irrigate in all the socket. If there is periapical infection, if there is parental disease, if there is presence of pus, then you have to irrigate it. Otherwise, do not irrigate immediately after extraction. Put some gauze back. Curate if any periapical lesion is present. Compress the expanded buccal lingual plate to its original configuration. If you are planning for implant placement, do not compress the socket because if your residual radius is wide, you can place more wider implant. And the more wider implant are stronger as compared to thin implant. Check for any sharp bony projection. If there is any sharp bony projection, bony prominence are present, you have to remove it with either using bone file or bone bruiser. Use Mustin 2x2 gauze over the extraction socket. Again, the gauze pack should be placed for 30 to 45 minutes. Even though the clot is formed within 2 to 8 minutes, it is not stabilized yet. There is fibrin stabilizing factor, which takes about 30 to 45 minutes to convert insoluble fibrinogen into soluble fibrin. It takes about 30 to 45 minutes for fibrin stabilizing factor, which is factor 13, to act. So you must advise the patient to bite for at least 30 to 45 minutes. Placement of gauze pack. Whenever you are using a gauze pack, it should be moist, and better it should be always moist with betadine, so that it also acts if the chances of infection is low. And the gauze pack should be compressed directly over the socket, not like this. Okay, not in the occlusion. The gauze pack should put sufficient pressure over the extraction socket. Post-extraction instruction, very important. Bite firmly on the gauze for 30 to 45 minutes. Take only soft and cold food. Take medication prescribed by operating surgeon, mostly antibiotic. Immediately after removing the gauze piece, you should prescribe ibuprofen or paracetamol. Okay. So that analgesics should be taken before the effect of anesthesia wear off. So immediately after removing the gauze pack, patient has to take oral medication, and when you give them either ibuprofen or paracetamol, it takes about 90 minutes to work. Once the patient has taken the medication, after 90 minutes only it will work. So it's better to advise the patient to take medicine as soon as possible. As soon as he or she throw the gauze pack, they have to take the oral medication so that there will be no pain. Before the effect of anesthesia wear off, patient has to take the oral medications. Next, maintain oral hygiene. Brushing techniques should be advised after 24 hours. Rinses with mouthwashes. Also, warm saline gargle. Don't constantly spit or rinse blood or saliva because it will lead to continuous bleeding. Taking hot food will lead to vasodilation. And drinks, if you use a straw to drink, is also avoided because if the patient uses a straw, it will create negative pressure and it will lead to bleeding. Again, smoking also creates negative pressure. It will dislodge the clot. Also, smoking has negative effect on blood supply. So again, it will lead to delayed healing. Physical exercise is also not advised because physical exercise will increases the BP, and again it will lead to post-operative bleeding. And post-operative oozing of blood, capillary bleeding is normal till 24 hours. So we advise not to spit for 24 hours. Sequence of tooth extraction is always you have to extract the upper tooth before lower tooth. Maxillary tooth should be extracted prior to mandibular teeth. Posterior tooth should be extracted before interior tooth. The two teeth that are most difficult to remove are the first molar and canine, should be extracted at last. The sequence is maxillary first followed by mandibular, posterior first followed by anterior, except first molar and canine because the first molar and canine are the strongest tooth. So if you remove the adjacent tooth, it's be easy to luxate those two. So at last, first molar and canine are extracted. For example, if right quadrant mandibular teeth and maxillary tooth is to be extracted, then the sequence will be maxillary posterior teeth leaving first molar, maxillary anterior teeth leaving canine, then maxillary first molar, then maxillary canine, followed by mandibular teeth, mandibular posterior teeth leaving first molar, mandibular anterior leaving canine, mandibular first molar, and mandibular canine. Wound healing of extraction socket. The healing of an extraction socket is a specialized example of healing by secondary intention. So the extraction socket always heal by secondary intention. There is secondary healing. It's not the primary healing. So sequences, there is hemorrhage and clot formation for 1 to 2 days. Organization of clot by delineation tissue takes 3 to 7 days. Replacement of granule tissue by connective tissue and epithelialization of would take 4 to 35 days. After that, replacement of connective tissue by coarse alveolar bone for 6 to 8 weeks. Finally, the reconstruction alveolar process and replacement of mature bone by mature bone will take 4 to 6 months. Only after 6 months, whole of the bone is found. That's why in traditional technique, conventional technique, when you extract the maxillary teeth, we advise the patient to wait for 6 months before placement of implant. Though newer techniques are there, where we place the implant immediately after extraction. Immediate loading is also there. But for normal bone to form, it will take around 6 months time. Complications during extraction are fracture crown, root, alveolar bone may occur, damage to adjacent teeth, especially if you are removing the 8. You may damage the 2nd molar, ingestion or inhalation of tooth, bleeding, and damage to soft tissue. If the tooth or root fracture causes maybe faulty technique, no preoperative radiograph to show root pattern, to dense alveolar bone management is, as a rule, all fractured roots should be removed as soon as they are produced. In some situations, we leave root in situ. If so, patient should be informed. Policy for leaving root is excessively traumatic if it is near vital structure, if it is near maxillary sinus, if it is near neurovascular bundle, if the size is smaller than 4 to 5 mm, if it is deeply embedded, and if there is no infection, no redundancy on apex, then you can remove the root. Otherwise, you must have to remove the root. Do not leave the root within the socket, because in latter case, it will lead to infection, and again, the patient will have severe pain. Fracture of alveolar bone, extraction of canine is frequently complicated by fracture of the labial plate. Alveolar fragments which has lost 1/2 of the periosteal attachment should be removed. If it is well attached to the periosteum, should be sutured back. Because if it is attached to the periosteum, the blood supply is intact, it will heal. If the attachment of periosteum is lost, the blood supply will be compromised, so it will undergo necrosis. In such condition, we have to remove the alveolar fragments. Tooth may lead to fracture or amalgam failings, deviation of adjacent crown, management is failing of respective tooth. Maxillary tuberosity fracture is commonly associated with maxillary horn extraction. Okay. So what will you do if the maxillary tuberosity fractures? If the tuberosity fracture, if it is attached with the tooth, you have to remove it. If the tuberosity is still attached with the periosteum, just put mucosal suture and leave it as it is. So the concept is, if the tuberosity is still attached with the mucosa, blood supply will be maintained. You can leave as it is, it will heal. If the tuberosity has fractured and if the attachment with the periosteum is gone, the periosteum is no more attached with the mucosa, then in such condition, blood supply will be, you have to remove the bone. Deadly condition, aspiration of extracted tooth. You can't do anything in such condition. You have to take the assistance from the radiologist. You have to take the radiograph and you have to remove the tooth using bronchoscope. And it usually happens if the patient has opened his mouth wide, usually in case elderly patient where the gag reflex is very less. If the tooth slips from your forceps, it may enter into the respiratory tract. It will enter into the lungs, especially it will enter into the right lungs in the right bronchus. Because the right bronchus is more vertical, it is more wider as compared to left bronchus. Post-extraction complication can be bleeding, dry socket. के को लाग्यो होला? के पढ्नुहुन्छ? आउनु पर क्लास त सकिन लाग्यो आज? आज फर्स्ट डे हो। ल बस्नु। आउनु। कुन सब्जेक्ट कति बजे स्टार्ट भएको? क्लास स्टार्ट भएको कति भयो? मेजर पार्ट त सकिसक्यो, सर्जरीको आज लास्ट क्लास हो। अरु क्लास पनि कमन भइसक्यो। So post-extraction complications can be bleeding, dry socket, orovantral fistula, surgical emphysema or infection. So immediate bleeding is due to traumatic extractions, soft or bone tissue injury, injury to blood vessel, platelet deficiency. If the platelet count is less than 50,000, the chances of bleeding is very high. Platelet dysfunction, if the patient is taking aspirin, or if there is bone branch disease, then in such condition also bleeding is the tendency of bleeding is high. The delayed bleeding is cause due to clotting factor deficiency. It may be hemophilia A, B, or C, or it may be defect with any other clotting factor. Chronic liver disease, it may lead to cirrhosis. In case of liver disease, what happens? The clotting factor which must be synthesized in the liver is compromised. So the clotting factor is not synthesized in the liver, and it will lead to severe bleeding. If the patient is taking any heparin or warfarin anticoagulants, warfarin is usually prescribed in case of if the patient has undergone a stroke or cerebrovascular accident. If the patient has any cardiac problem, in such cases, warfarin is prescribed. Warfarin is oral and anticoagulants, and the target INR is maintained at 2.53 or 3.5 depending on the severity of injury. So in such cases, if the INR is more than 2, it's better to take consultation with a medicine called physician. And as I've already told, you have two options. Either you can go for bridging therapy or non-bridging therapy. In case of bridging therapy, you have to stop the warfarin, you have to start the low molecular heparin, you have to observe INR. If the INR falls below 1.5, then you have to skip that day low dose heparin dose or reflection, and you can go for surgery. Once the surgery is completed, you have extracted the tooth. Again, you have to start both warfarin as well as low molecular weight heparin. Again, you have to observe INR. Once the target INR is reached, let's say if it is 3.5, then you have to stop the low molecular weight heparin and continue with the warfarin. That is the traditional bridging technique. In case of non-bridging technique, you have to continue the warfarin. You have to extract the tooth, no problem. Whether it is a non-surgical extraction, even if it is a grade 3 mobile tooth extraction, you have to put some gel foam or Surgicel and you have to suture it back and apply pressure, and you have to observe the patient. In hypertensive patient, again, the chances of bleeding is high, especially if the patient is more than 40 years. You must check the blood pressure. Prevention of excessive bleeding can be obtained history of prolonged bleeding, previous episode of bleeding, family history and drug history, use a traumatic surgical technique, obtain good hemostasis at the time of surgery, provide proper patient instruction. INR is used to measure therapeutic anticoagulation effect. Normal INR is 0.7 to 1.2. It is within 0.7 to 1.2. It's okay. No need to worry. If it is more, then you have to manage accordingly. Minor surgery can be performed if INR is 2. If INR is more than 3.5, consult physician. Primary control of bleeding, pressure pack. If bleeding persists, additional measures to control bleeding is application of gelatinous sponge or gel foam. You can apply a gel foam over the sock and you can suture it. Application of Surgicel. It is also known as oxidized regenerated cellulose. Application of topical thrombin. In most of the cases, if there is a bleeding from the socket, all of them can be measured by local measures. You don't have to inject anything systemically. The pressure pack is the best technique. Either you can use tranexamic acid soap gauze pack or retinol soap gauze pack. You can use gel foam and you have to switch up. Dry socket is the most common complication, especially after extraction of third molar. Okay, mandibular third molar. There is something called Bones fibrinolytic theory. What it states is whenever there is trauma and or infection, it will cause inflammation of bone marrow. So inflammation of bone marrow will release tissue activators. These activators will convert plasminogen into plasmin. Plasmin is active state. Plasminogen is inactive state. So plasmin will cause lysis of fibrin and formation of kinin. So once the fibrin is lysed, it will lead to dissolution of blood clot, and this condition is known as dry socket. So dry socket is simply a dissolution of blood clot. It may be due to either excessive bleeding, it may be due to creation of negative pressure, it may be due to smoking or any reason. Due to any reason, if the socket clot is lost, it will lead to dry socket. And characteristic feature of dry socket is there is burning pain on the third day of extraction. So Newton's hypothesis of dry socket suggests that fibrinolytic hypothesis was due to the presence of organisms like Trichonium denticola, Bacteroid oralis, and Bacterium melangicosus. So Newton's hypothesis suggests that dry socket is due to bacterial infection as well. Now the causes, previously it was thought that there is no role in bacteria, but now it is considered the dry socket is due to, it is a multifactorial cause. It may be due to bacterial infection, poor oral hygiene, surgical extraction or traumatic or smoking. All of these will lead to dry socket. So symptoms are there will be severe pain and discomfort from the extraction site that starts on the second or third day after extraction. Intraoral halitosis will be there, bad taste in the mouth. signs are, when you examine the patient, there will be increased socket, clot is not there, exposed bone will be present, remaining food debris inside the socket, inflammation of the soft tissue, and delayed healing of the socket. So treatment is cleaning the socket by removing the food debris, using saline irrigation for better cleaning, forming the blood clot again inside the socket, using medicated dressings such as Elvozil for rapid pain relief and analgesic for the pain. You have to remember is, in case of dry socket, you should never curate the socket because all of the clot is not large. Some of the clot is still remaining there. So just do the irrigation, and also the Elvozil or previously or traditional method is zinc oxide eugenol dressing. Even though zinc oxide regional dressing will provide some pain, it is only symptomatic relief. It has a uptrending effect on nerve terminals. So patient will have symptomatic relief, but the problem is if you put any foreign body in the socket, it will delay the healing. So it's better not to put any foreign body within the socket. Just prescribe painkiller, do the irrigation, advise the patient to maintain the oral hygiene. And that's all. The most important thing: never curate the patient in case never curate the socket in case of dry socket. It is Elvozil. It is used for symptomatic treatment of dry socket. It consists of anesthetic agent, which is butamben, iodoform. It has antimicrobial role, and it also consists of eugenol. Eugenol, it causes upturning of, it has soothing effect on nerve terminals. So patient will have immediate pain relief. In case of oroantral communication, if it is 2 mm or less, pressure pack is sufficient. If it is between 2 mm to 6 mm, suturing should be done. If it is more than 6 mm, then you have to operate it surgically. Other complication can be TMJ dislocation. If you are extracting the mandibular torna, if you apply excessive pressure, then in such cases, the TMJ may get dislocated. Condyle will come out from the glenoid fossa anterior to articular eminence. Now, what will you do if there is TMJ dislocation? There is Hippocrates maneuver, where you have to apply the pressure on the either buccal surface self area or the last erupted tooth. You have to apply your thumb pressure over the either last erupted tooth or buccal self area, and the remaining 4 fingers should be placed at the anterior region of the mandible in the chin area, and you have to apply the simultaneously downward pressure over the posterior mandible, and simultaneously you have to apply upward pressure in the anterior mandible, and you have to take it back. The most important thing in case of TMJ dislocation is we have to reduce as soon as possible, because if the TMJ dislocation occurs for longer time, while the muscles which are present there will go into a spasm, the pterygomasseter muscle and medial pterygoid muscle, once it undergoes into a spasm, it's very difficult to reduce. So in such condition, you have to reduce the TMJ dislocation under general anesthesia. Under general anesthesia, you have to intubate, then you have to give the muscle relaxant. Once the muscle relaxant is given, the muscle, the muscles which has undergone into a spasm, especially the masseter muscle and medial pterygoid will get relaxed, and then you can reduce it. Once it is reduced, you have to put the grip bandage for at least 24 hours. Advise the patient not to open their mouth so wide. Otherwise, the chances of again redislocation is very high. In case of dislocation, mandibular condyle will go anterior to the articular eminence. During reduction, you have to apply the pressure in the either in the buccal surface area or last erupted tooth. You can use the gauze piece. It may be painful. And the rest 4 fingers should be applied at the lower border of mandible, and your force should be superiorly in the anterior region and downward in the posterior region. And you can take back the mandible to its normal position. If you do immediately, it's fine. If it's delayed, it's very difficult to reduce the TMJ dislocation. And in some patients, what happens, the articular eminence is reserved. Usually in case of old age patient, in such cases, there is chances of recurrent dislocation. In such cases, what we can do is we can just do immunectomy, so that the condyle can itself come out and go. When the patients open their mouth, it will come anterior to articular eminence, and again, while closing the mouth, it will enter into the glenoid fossa. So immunectomy is one of the surgical treatment for recurrent dislocation. Okay, that's all. Yeah. भन्नु भन्नु सुन्दैछु। मोस्ट अफ द टाइम मेडियल के अरे इन्फेरियर नर्भ ब्लक दिँदाखेरि हुन्छ, मेडियल टेरिकोइड मसलले गर्दाखेरि ट्रिस्मस हुन्छ। अरू ब्लकहरुमा हुँदैन। इन्फेरियर नर्भ ब्लकमा मात्र ट्रिस्मस हुन्छ, ब्लकले गर्दा भएको हो भने। ट्रिस्मसको रिजनहरु धेरै छ, तर इन्फेरियर के अरे एनएससी केसमा इन्फेरियर नर्भ ब्लकले गर्दाखेरि मात्रै हुन्छ, अरू ब्लकले गर्दाखेरि ट्रिस्मस हुँदैन। ट्रिस्मस भएको छ भने त सबभन्दा पहिले अब त्यो फाइब्रोसिस भएको छ, फाइब्रोसिस ब्रेक गर्नु पर्यो। फाइब्रोसिस ब्रेक गर्नलाई माउथ ओपनिङ एक्सर्साइजहरु गर्न लाउनुपर्छ, रिहेबिलिटेसन गर्न लाउनु पर्यो। तर प्रब्लम के हुन्छ भने फाइब्रोसिस भएकोलाई माउथ ओपनिङ एक्सर्साइज गर्न लाग्यो भने पेशेन्ट विल हेभ सिभियर पेन। इन सच कन्डिसन यू हेभ टु प्रिस्क्राइब द मेडिकेसन आइदर मोस्टली वी गिभ डाइक्लोफेनाक 100 mg SR for pain relief, and the patient has to do mouth opening exercise. You can use either Heister one instrument also, you can use that Heister for mouth opening exercise. The primary treatment is mouth opening exercise because there is fibrosis, you have to break the those fibrous band. बाकी सबै सिम्प्टोमेटिक ट्रिटमेन्ट मात्र हो। डेफिनेटिभ ट्रिटमेन्ट भनेको माउथ ओपनिङ एक्सर्साइज गर्नै पर्छ, पेन भए पनि गर्न लाउनु पर्छ। जति लेट गर्यो त्यति गाह्रो हुन्छ, माउथ ओपन नै हुँदैन पछि गएर। ओके, आज सर्जरीको लास्ट क्लास हो। अब अरू क्लासहरु लिनुहुन्छ होला। मोस्ट अफ द जुन कमन टपिकहरु छ सबै कभर गरेको छ, त्यो चाहिँ पढ्नु पर्यो। त्यस्तो केही डाउटहरु हो भने सोध्दा हुन्छ।